Thank you very much. Okay, good afternoon, everyone. I'm going to present to you on sticky bugs, Rifampicin for biofilm treatment in Staphylococcus aureus prosthetic valve endocarditis. I'd like to start with a case, and we've compressed this case a little bit to make it succinct, and yeah, so please bear with me. This is a 41-year-old male who was diagnosed with rheumatic heart disease at the age of 10, was in follow-up for several years, but then defaulted follow-up at 15 years of age. His last tested HIV negative on ELISA and did not have a previous TB history, and did report tick use, but not IV. He's also a smoker with 3 pack years of smoking, but no alcohol use or abuse. In his initial presentation on May 2021, he presented to a clinic with a 3-month history of progressive exertional dyspnea, which is characterized by paroxysmal nocturnal dyspnea and orthopnea, and also by loss of weight. On examination, he had clinical signs suggestive of heart failure. He was pale and was discovered to have an anemia of 6.5. He had a raised JVP, a pansystolic murmur, grade 4/6 over the mitral area with a hyperdynamic precordium, a pulsatile liver, but his lungs were clear and he did not have peripheral edema and he was not in acute failure. A workup was initiated and an echocardiogram was done, which showed a preserved ejection fraction, but a thickened mitral valve and a thickened aortic valve with vegetations present on the aortic valve. And was also noted to have severe regurgitation of aortic, mitral, and tricuspid valves. Blood cultures were done consecutively and all showed no growth. And serology was then done for blood culture negative affected endocarditis, which showed positive serology results for Bartonella, Henselae, and Quintana, and also positive serology for Coxiella, but only for the phase 2 antibodies and not the phase 1. Based on this workup, the diagnosis of Bartonella culture negative affected endocarditis was made. He was started on a regimen of doxycycline and ceftriaxone initially for a month, and he was booked for surgical treatment for repair of his aortic valve and mitral valve, replacement of aortic and mitral valve and repair of the tricuspid valve. We got involved in this case after surgery just last week. His post-operative pathway was unfortunately beset by several complications. He was noted to have residual cardiac failure in ICU in the days after surgery. He developed a heparin-induced thrombocytopenia also in the days after surgery, which was addressed by stopping of heparin and platelet transfusions and subsequently resolved. He also developed a right hemithoracic collection, and an ICD had to be placed to drain this. And of note, investigations on the resected aorta and mitral valve showed with 16S ribosomal PCR analysis, more than 99% sequence concordance for Bartonella Quintana. Day 15 post-surgery, we were called. The patient was noted to have a temperature of 38.5 degrees centigrade repeatedly and had worsening delirium. On his chest X-ray, there was increased opacification of the right hemithorax with an ICD still in situ. We ordered investigations. The blood culture was already done and came back showing gram-positive cocci and clusters. The ICD drain was noted to drain exudative fluid on fluid chemistry analysis, and a culture was done, but was still pending at the time of the first consult. And an emergent echocardiogram was done by the cardiologist, which showed a vegetation on the aorta valve at that point. So our assessment at this point was that the patient was likely having staphylococcal prosthetic valve infective endocarditis, with the likely source being the right empyema that he had developed post-operatively. We immediately started antibiotics. They were initially started empirically with meropenem, vancomycin, and rifampicin. Of note, the patient was also continued on azithromycin for long-term treatment of his Bartonella Quintana. He was initially on doxycycline, but developed a peptic ulcer, so had to be switched to azithro. Cultures started coming back in the day after starting of antibiotic treatment and showed an MRSA, which was vanco-sensitive and rifampicin resistant, both on the blood culture and on the ICG fluid culture. This kind of brought us to the clinical challenge, which was how to tailor the antibiotic treatment for this patient who's obviously very sick. And this is where I'd like to take you back to the guideline recommendations. And these are the guidelines from the American Heart Association and European Heart Society, which kind of both notes that Staph aureus prosthetic valve endocarditis requires combination antibiotic treatment. The mainstay of this treatment in MSSA consists of high-dose cloxacillin for 6 weeks, and in MRSA, the cloxacillin is substituted for vancomycin, also for 6 weeks. Both of these guidelines note several alternatives to vancomycin, such as daptomycin, ceftaroline, and linezolid, but they are noted to have limited clinical evidence and should only be used for salvage therapy or in case there are contraindications to vancomycin. Now, the second antibiotic that is recommended to be used is high-dose rifampicin, also over a course of 6 weeks. And importantly, most guidelines note that it's optional to start the rifampicin 3 to 5 days after the start of the beta-lactam or vanco to prevent resistance development from taking place. Staph aureus rapidly develops resistance to rifampicin, and the idea is that initiating cloxacillin or vancomycin first might prevent this from happening. The third treatment that is recommended is an aminoglycoside, gentamicin, that should be continued for 2 weeks. And the hypothesis here is that gentamicin and cloxacillin work synergistically to treat the infection, but there's very limited evidence on this. And obviously, surgical care treatment in these cases is often required for definitive management. Now, in our case, the MRSA isolate was already rifampicin resistant, and this brought us to a clinical dilemma that we could not really use rifampicin in this case. So the clinical question for us was, what is the actual value of rifampicin in the treatment of prosthetic valve endocarditis? And I'd like to discuss that with you now. First, I'd like to just go back and tell you a little bit about infective endocarditis in general. We can divvy up endocarditis cases into culture positive and culture negative cases. Culture negative cases can be, of course, due to non-infectious endocarditis sources, which should not be forgotten, but can also be due to blood culture negative infective endocarditis, which was the initial diagnosis for our patient. Culture positive infective endocarditis can be divided up into either native valve endocarditis or prosthetic valve endocarditis. And as you can see, there's myriad different causes that can cause infective endocarditis, but it's important to note that both coagulase negative staphylococci and Staphylococcus aureus are very often involved in prosthetic valve endocarditis, which is what we're dealing with in this case. Prosthetic valve endocarditis, or PVE, is a relatively frequent complication of prosthetic valve surgery. The lifetime risk for patients undergoing such procedures is from 1 to 6%, according to several reviews, with an incidence of about 0.3 to 1.2% per patient year. The condition is associated with very significant mortality, up to 40% in some case series. And it's important to note the distinction between early PVE, usually defined as onset within 1 year, and late PVE, which happens after 1 year. Early PVE is associated with hospital-acquired infections, which are acquired during or shortly after surgery or during ICU admissions of patients. And the risk of these is greatest in the weeks after surgery, which is also the case in our patients. And importantly, in these cases, staphylococci are very much predominant. In late PVE, the mechanism, the etiology likely involves either community-acquired bacteria or there are associations with transient bacteremia after minor procedures such as dental procedures or minor surgery. And therefore, the microbiological pattern for late PVE resembles native valve endocarditis. As you can see on the right in the survival graphs, we can kind of see the significance of the pathogen. In the top survival plot, you can see that cases of PVE caused by Staphylococcus aureus are associated with a hazard ratio of 1.8 for death, and healthcare associated cases of PVE have a hazard ratio of 1.5 for death. So both healthcare associated infections and Staphylococcus associated infections are very severe and have an increased likelihood of leading to mortality. Now, on the epidemiology, this is data from a large review conducted by Wang et al. In 2007. And they showed again that of cases of PVE denoted in the blue pie chart, all dark blue cases were caused by Staph aureus. So you can see that in North America and Europe, particularly, Staph aureus is a very prevalent causative pathogen for PVE. But as you can also see in South America and Africa, the prevalence of Staph aureus drops off a bit. It's important to note, though, that Africa in this review, or in this systematic review, was defined as several hospitals in Southern Europe, the Middle East, and one hospital in Africa, namely Grootesklere in Cape Town. So I think it's actually safe to say that there isn't really much African data on the causative pathogens involved in PVE. So the pathogenesis of Staph PVE, I find this very interesting. Most models or hypotheses propose that this starts off with endothelial damage or inflammation, usually due to surgery. You can think of surgically affected sites or suture points. These points have disruptions of the endothelium, on which platelets and fibrin and fibrinogen then start to adhere, forming a thrombus. If you subsequently get bacteremia, either due to intraoperative seeding or due to bacteremia from a peripheral source, you then obviously have Staph aureus floating around in the blood. And Staph aureus has these adhesion molecules called M-scrams, microbial surface components, recognizing adhesive matrix molecules that recognize fibronectin and fibrinogen. And this molecule is then used to recognize the thrombus and for the bacteria to then adhere to the thrombus. From adherence to the thrombus, the bacteria can then migrate to the prosthetic valve and start forming a biofilm on the prosthetic valve itself. Just a little bit on biofilms. Biofilms are very important in the pathogenesis of Staph aureus and epidermidis infections. Both these pathogens are very much able to form biofilms on implanted medical devices. And of note, the pathogenesis is different for MSSA versus MRSA. MSSA tends to form biofilms in a polysaccharide matrix, so kind of like a sticky matrix that the bacteria sort of stick into. MRSA expresses different surface proteins and manages to link up using extracellular DNA. So the mechanism is a little bit different, and on the right graph you can see that that's also reflected in the electron microscopy images of biofilms for these two bacteria. Now, our question is, what is the evidence base for the use of rifampicin in treatment of the biofilm in these staphylococcal infections? The rationale is that rifampicin has an additional benefit in infections by staphylococci or foreign material in the body. Unfortunately, this has not been prospectively studied in Staph aureus PVE cases. And the available evidence that I found from the guidelines is limited to 2 animal studies of experimental models of disease and 1 human retrospective chart review. And I'd like to finish this presentation by going over those articles to just kind of distill what the actual evidence tells us. So the first series of animal studies was performed by Chouard and Lucette et al. In the early 90s on rats. And just to tell you a little bit about the experiment, these rats received implantation of subcutaneous tissue cages, so small kind of tissue cages that were inserted under the skin. Interstitial fluid then kind of seeps into the lumen of the cage over time, and after a while, this fluid is then artificially inoculated with MRSA. Subsequently, these rats received different combinations of antibiotics. In this study, they used vancomycin, fluoroxacin, and rifampicin. Subsequent to that, the cage fluid was serially sampled and cultured to check for an effect of antibiotics of infection of the cage fluid. And in these studies, as you can see on the graph of the left in the bar chart, the dark shaded proportion represents tissue cages that remained culture positive. The light shaded proportions, tissue cages that became negative. And you can see from the two bars on the left that a monotreatment with either vancomycin or fluoroxacin had limited effect, and those tissue cages tended to remain culture positive, whereas combining these treatments with rifampicin yielded higher rates of fluid sterility, and this was statistically significant. Another animal experiment actually yielded very different results. These were studies performed more recently on rabbits, and this was in an experimental endocarditis model. These rabbits received catheterization via the carotid of the left ventricle, and the catheter was then left in situ. 24 hours after that, a peripheral vein was inoculated with MRSA, and then after that, blood cultures were taken to confirm Staph aureus bacteremia. Subsequent to that, antibiotics were administered, again in different combinations. In this study, used daptomycin, gentamicin, and rifampicin. And at the end of the treatment duration, the animal was sacrificed, autopsy was performed, and AV vegetations on the aorta valve were cultured. And again, as you can see in the table on the right, in this study, monotreatment with daptomycin actually yielded the highest rate of culture negative aorta valve vegetations, and addition of rifampicin to daptomycin decreased the rate of vegetation sterility, suggesting that daptomycin and rifampicin combination in this model actually had a deleterious effect on success. So as you can see, these animal studies actually are discrepant in their results, and this brings us to the one study that we have in humans. This was performed, this is a retrospective chart review, a single center study performed in New Zealand, and these authors reviewed 152 episodes of staphylococcal infective endocarditis who underwent valvular replacement surgery. And they looked at a very long window of cases starting in 1963 and ending off in 1999. So I'm sure that standard of care also changed significantly during the period of study. 91 of the 152 cases were native valve endocarditis, and 61 cases were prosthetic valve endocarditis, and those are the cases that we'll be focusing on now. They combined cases of Staph aureus and coagulase negative staph. These patients were treated in accordance with standard of care with various combinations of beta-lactams or vancomycins, rifampicin, and gentamicin. The duration of treatment until surgery obviously differed because it's a retrospective chart review, and all patients eventually underwent valve replacement because that was the inclusion criterion for the study. Statistical analysis here was done by multivariable logistic regression. The predictor was ad hoc selected subgroups, so basically data-driven subgroups of patients receiving different treatment combinations. They managed to correct this analysis for the duration of antibiotic treatment, which you can imagine is very important in this case. And the endpoint for the analysis was a positive culture of an excised valve. So the valve is eventually excised, then cultured, and then observed whether the culture was positive or whether the valve was now sterile. And culture positive had to be an organism matching the pretreatment blood culture. Importantly, this is obviously a surrogate outcome or a proxy outcome, and we do not have data in the study on actual clinical outcomes such as survival or time to hospital discharge. Main results of the study, and I'm sorry because this slide is a little bit busy. The authors tried to compare patients who had received single treatment versus any combination of antibiotics. And as you can see in the group that I highlighted with blue, patients who underwent a single antibiotic treatment, and this was most often with beta-lactam or vancomycin, 57% of these patients had a positive culture of the excised valve. Patients who received any combination of treatment, and this was really a combination of patients who received continuous triple treatment or dual treatment or partial combinations on and off, these patients had only a 30% culture positivity rate on the excised valve. And in the adjusted multivariable analysis, that yielded an odds ratio of 5.9. But as you can see, the confidence interval is relatively broad and starts off at 1.3. But the analysis was statistically significant. However, in the sub-analysis where the authors looked at any treatment combinations, including rifampicin versus combinations of treatment without rifampicin, we can see that in combinations that did not include rifampicin, positive culture rates were 37%, and in any combinations including rifampicin, the culture positive rate was 33%. These percentages are very comparable. The difference is not significant. And in the group highlighted in blue of patients on rifampicin, the cultured organism on the excised valve had developed rifampicin resistance in 2 out of 6 cases. Lastly, these authors also looked at native valve endocarditis versus prosthetic valve endocarditis and showed that in native valve endocarditis, combined treatment did not show any additional benefit. Also, they make the case that in 4 patients in the prosthetic valve endocarditis group who were treated continuously with triple treatment, all of these 4 patients had negative valve cultures. And this obviously sounds good, but the group is very small. Yeah, so just to conclude from all this data, the hypothesis that rifampicin has effect against biofilms of staph PVE is based on animal studies that actually have conflicting results. In humans, limited clinical data suggests that combination antibiotic treatment is important, but it actually does not clearly support the addition of rifampicin per se. Current standard of care and the severe nature of staph PVE obviously limits us a little bit from further clinical research in this area. Thank you very much for your attention, and I'm hoping to receive any questions. Thank you.
Thanks very much, Lucas. That's wonderful. If you could just stop sharing your screen.
Yep.
Yeah, very interesting cases and very interesting discussion. Sorry, thank you. And as you say, some conclusions which, unfortunately, the robustness of the data is not fantastic. While people are thinking their questions, and I'd love to hear Gary's views and in particular, what in the retrospective study in those treated with rifampicin, do we know how many had the staffs were sensitive to rifampicin?
Yeah, it's a very important question. The authors actually don't report that. They report methicillin resistance, but not rifampicin resistance at baseline.
So that's a pretty critical question, I guess, when one's thinking about outcomes. Adrian, you got your hand up.
Hi, Mark. Thank you very much for a great presentation. I just wanted to make one comment. The problem is that the Staph aureus, the MRSA or MSSA, it has a high intrinsic mutation rate at the encoding, the gene that encodes for rifampicin binding, so-called RPOB. So if you have large numbers of Staph aureus that are exposed to rifampicin alone or in combination, you quickly select for a rifampicin resistant subpopulation. You saw in the presentation that some of the patients at the end of therapy, when they cultured the valves, they were sensitive before, and then after the combo or triple therapy ended up with resistant ones. So the problem is that the studies don't, it's impossible down the line unless you check, and I don't know how you're going to do it, to follow up the impact of or the collateral damage due to rifampicin. And the other comment I wanted to make, Mark, is the dosing of the rifampicin, because there seems to be, a difference in opinion. I think the initial one was 300 every 8 hours in combination with Genta, for 2 weeks, and then Vanco, blah, 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 depending on if it's an MRSA, but other people have recommended lower doses, like 600 once daily or 300 every 12 hourly. So I'm never know when people ask you, shall I add rifampicin, then, and at what dose and for how long? It's a nightmare.
Thanks, Adrian. And maybe Gary's got his hand up. I mean, maybe Gary, you can help us with that specific question and whatever other comment or question you had, Gary.
I can't really comment on the dose. I think we've been underdosing rifampicin ever since we got our hands on it. So I think 300 milligrams twice a day is far too little. I think this is an excellent example of how flimsy evidence can be. The dogma has been for decades that you have to have Rif and Vanco. Every cardiologist will tell you that. Every international guideline and local guideline will say that. And it's like written in stone. And it's based on one retrospective study and 2 animal studies, one of which says it didn't work and the other said it did work. So what could be more pathetic than that? We know from an RCT in MSSA that rifampicin adds absolutely nothing. And this is a very old idea that Rif is magic for biofilms, but I don't think it is magic for biofilms. It's magic for selecting resistance in biofilms. So I really think we need to really go back to the drawing board and come up with better animal models, better combination therapy. I think it is likely that vancomycin on its own might not do the job. And you may need combinations, or you may need a different drug, like daptomycin might be better. But we need to start putting out the message that the guidelines are purely opinion-based, and how pathetic they are, because cardiologists and others involved in the care of prosthetic valve endocarditis just simply don't know that. They just accept this is dogma, it works, and therefore we must do it.
Thanks, Gary. And yeah, I agree. But one of the issues that Lucas brought up in his presentation, and something that's also dogma or discussed in orthopedic infections, prosthetic joint, is delaying the initial rifampicin. And I'm guessing that relates to trying to reduce the bacterial load and therefore reduce the likelihood of rifampicin mutation. So, I mean, it's slightly different in prosthetic joint infection because there's a question mark about increased resistance from the skin then infecting the wound. But I think there are a lot of different questions around this to be answered. Sipo, I saw you had your hand up. So while Adrian's making his point, perhaps you could reinstigate yours. But Adrian.
Mark, to come back to Gary's comment, which I support 100%, in that I believe that some of the new agents, although they're very difficult to study from a RCT point of view, are inherently more active. So if you look at some of the studies for MRSA, for example, that were cultured in patients with endocarditis, the most active drug, bactericidally speaking, with the lowest MIC is actually a 5th generation cephalosporin. And then other drugs like daptomycin, and then all these long-acting glycopeptides like erythravancin. There's a trial actually ongoing globally for the treatment of staph endocarditis, including prosthetic valves. The other one is telavancin. So until one has better data, I mean, you mentioned the issue that there was a dogma that you should delay the addition of rifampicin for exactly that same reason. It's a nightmare. I think the biggest nightmare in my experience where we got these previously in Johannesburg referred to was the timing of surgery. And the whole multidisciplinary team, I think, in deciding what to do rather than the surgeons or the cardiologists doing it on their own. Anyway, thank you.
Thanks very much. I mean, Gary, I'm not sure if you want to come back on any of those issues, or Sipho, did you have you wanted to make your comment?
No, Mark, I think you had made the comment I wanted to make. It was relating to what learnings can we take from prosthetic joint infections and their use of rifampicin in that instance. And as you highlighted, some of the strategies are delaying, but obviously it's different because in prosthetic joint infections, there are different strategies in relation to the prosthetic material. Either it comes out or there's a delay in removing it and seeing all of these. So there is a bit more of an understanding of Staph aureus and biofilms in prosthetic joints. I think, as Gary highlights, I think certainly in sort of cardiovascular disease, there isn't any evidence. And the question is, how can we use learnings from orthopedic prosthetic infections to translate to cardiovascular disease with prosthesis?
Thanks very much, Sipho. So maybe we could have a last comment from linezolid Wasserman about, we didn't hear much about linezolid in this. I mean, obviously linezolid and rifampicin concerns, but Sean?
I don't have much to add. I mean, I think Gary's point was brilliantly made. I mean, it's just crazy how this works. There has been a systematic review of linezolid for Staph aureus bacteremia, right? I mean, just this combination of lots of observational studies, and it seems to perform as well as vancomycin. And look, I mean, I don't think the exact population or infection type is known where this is like, where the optimal use of linezolid is, but we keep talking about it. It's a very attractive agent, especially because it can be taken orally with very good bioavailability. And in less than a month, in under a month of treatment, it's very well tolerated. And it's something that's kind of begging to be studied properly, I think.
Thanks very much. Okay, I think that we're